Hi, this is a very brief introduction to the perinatal periods of risk approach. It will give you a broad overview and also point you towards specific things to read and do as homework before the live session so that we can be ready to have real discussions and skip over some of the simple stuff and get to the harder stuff in the live session. And my name is Carol Gilbert, and it's City Match. I do have some resources on our shared website, the 4 articles, which I'll show you in a minute, and some homework assignment things, and some tools for later when you're actually doing PPOR. Those are also on there. These are the 4 articles, published quite a while ago now, but still really the analysis articles are very, very detailed, and you can actually learn how to do it just by reading those articles. But you won't have to read all of them just for this course, but you may refer to them later when you're doing the work. So what is the perinatal periods of risk approach? It's a simple method, an analytic method that gives you a framework and steps for investigation, which is very helpful because it's easy to get lost in the trees and it's easy to not use all the information that you have. And that's what we want to do. But it's also a tool to be used as a part of a larger urban community planning process. And we use the word urban loosely. It's any community that's large enough to use PPOR. It's to be used with communities. So one of the key things in the overview is readiness. PPOR does require that the community be ready to do this. And there's a little video about the story of Antelope Valley in California who used PPOR, and they were featured in one of the 4 articles. There's a homework, which is reading a particular section on readiness in the PEC article, page 866. And then you can take a look at the readiness tent exercise. It has a Word document that explains it and an Excel sheet. And this actually is used quite a bit with communities. And there are other models, besides the Peoples-Shep model that this was originally based on, that do a lot of the same kind of thing. This working with community and data is a tricky thing. And so you might want to take a look at these other 3 models that do some of this. The collective impact, results-based accountability is not quite in a broad community, but it does work with broad sectors, different sectors. And then the community toolbox has some real specific good stuff to work on. There's also analytic readiness. If you're going to do PPOR, you should know that access to the raw data files is often a real problem. So allow time. If you haven't got those, don't assume you can just get them easily. And be sure to get the code book. A lot of people don't get it, don't want to guess about what you're looking at. Data quality problems really do exist, and you need to be aware of them. You need to look for them, not accidentally hide them with the way you do your analysis. The analysis is simple, but you may need something more than Excel to handle the data, because it can be a large number of deaths or births that you're dealing with. And this is the homework assignment for this section. Analytic readiness is actually a section in the first article by Sappenfield, so it would be good to read that. There is a minimum numbers requirement for PPOR, and that is 60 deaths. 60 deaths will get you in through the phase 1 analysis with some pretty wide confidence intervals, but at least you can draw some conclusions. And then if you only have that number of deaths, you'll really have to rely on some other sources of information, qualitative information, but things like femur to dig further. And it's a good idea to use those to dig further anyway. If you have more deaths, say over 100, 200, in that range, you can start dividing populations, but also you can do a full phase 2 analysis to really get at all that the vital records data has in it for you. There are 3 vital records data files that we need for PPOR. The live birth certificates, which is there's a lot of births, then the small number of fetal deaths, and the small number of infant deaths. But those have to be linked to the birth certificates to be able to be used in PPOR. They're all produced in every state. Don't let your state tell you that they don't have them or that you have to do the linking yourself. They really are all there. And this is the very beginning of PPOR. The main idea at first is sorting the fetal and infant deaths into this 2x3 table. So there are 2 dimensions on the table. The first dimension is age at death. So fetal deaths are babies that die before they're born, and we restrict them in PPOR to more than 24 weeks or more for fetal deaths, and also 500 grams or more for all of the deaths. Neonatal deaths is the first 27 days. Post-neonatal deaths is 28 days to 364 days. Then the second dimension is birth weight. And our dividing line here is 1,500 grams, and that is the definition of very low birth weight. We do limit the birth weight to less than 500 grams, so we don't include those tiny babies, and there are quite a few, especially of fetal deaths. And then the larger deaths are divided into 3 groups by age at death. The smaller babies are all in one group. The way that they did this was by doing a cluster analysis and quite a bit of expert opinion. But they had very similar maternal risk factors and similar infant causes of death, and clustered these boxes together like this and figured out that all 3 in the top row really belonged together in terms of what solutions you would need. So if you figure out you've got a problem in one of these periods, you know you have a set of risk factors to investigate for that. You don't have to investigate everything. You just have to investigate the ones where you have a problem. So infant mortality is big. It's good to be aware of how big it is, and it's good to be able to focus on what really are the issues in your community. So this is what you do with it. You sort the babies into the boxes and make rates. The same denominator is used for each box, and they add up to the overall rate. You can use these to compare populations in a little more detail than you can with just the infant mortality rate comparisons that we often are left with. And you can see where the differences are. You can also track these over time. In this community, this is back through the 90s, so there was the green box, which is infant health period of risk, larger babies that survived the first month and died after the first month. They often die of sleep-related deaths, and you can see that rate went way down during the 90s, and then it plateaued, and that's how it is in most places now. But you can see the changes in the different boxes by doing this. But what you really need to know is what rates should we expect to see in each of those periods of risk? You know, for example, that blue box, the maternal health and prematurity period, that's all the babies that are less than 1,500 grams. Those babies are at more risk. Obviously, we expect more of them to die, so we expect that rate to be higher. So the question is really, how high is too high? What is really preventable? What is excess? And that's where the reference group comes in. The reference group is a real population based on maternal characteristics, maternal demographics, not health behaviors or health conditions. And there is a homework assignment here to read about how the reference populations are created and what the limitations are. A very good thing to be able to read before the next session. So in phase 1 of PPOR, the reference group is providing a baseline for us. It's an expected mortality rate under ideal conditions. If a death rate exceeds that baseline rate, we know there are deaths that could have been prevented. In vital records data, we don't really know which deaths could have been prevented, but we have an idea about what periods of risk, what populations there are preventable deaths, and how big the gap is. So where are the gaps is what phase 1 tells you. And this is what it looks like in practice. We started with those two different populations, and now instead of just comparing those two populations, we're going to compare them both to the same reference population. And we do this just by subtraction in PPOR. You can also use ratios and get confidence intervals if you don't have overlapping groups. But the subtraction is the standard way. It's simple. It does the job. So 8.8 minus 2.2, 2.4 minus 1.5. All those differences are called excess mortality rates, and you get a difference for each period of risk in each population. And you can put them into pie charts to better see how big they are, how big of a problem they are relative to each other within those populations. You can also go on to calculate excess numbers of deaths, and in that way you can put the two populations together. And if you have more populations in the county or city, you can put all of them together and make a bigger a sort of county-wide gap analysis here in this thing. This is just excess numbers of deaths by period of risk and race. And this really points us towards that blue box and then towards the green infant health period of risk. So the homework here is to learn the phase 2 analysis steps for yourself by doing the exercise. They're called exercises from Tuesday morning, June 2019. And use the answer key and just work through the analysis so that you can get a feel for what's really going on and where the difficult parts are. And then you'll feel much more tuned in for the next talk. And phase 2, we're going to spend some more time on phase 2 in the next talk, but the real main point of phase 2 is this. We focus on the populations and periods of risk with the largest gaps that we found in phase 1, and we ask two questions. What are the likely causes of the gap in your community, and what interventions are most likely to work, right? Those are the questions we need to answer. And to get those answers, we can do some further study with epidemiology methods, that is phase 2 mostly, PPOR, and some other simple calculations. And we can look at scientific evidence, we can look at community health assessments, and we can use fetal infant mortality reviews to really get some wide open information about what mothers think is going on. And from those those review teams can help identify patterns and systems that are contributing. So all of these activities are really part of phase 2 analysis. So it is not just epi. And it can go on for a long time. It can be as involved as you want or as simple as you have time to do. This is an example of something that happens during phase 2. So in this case, it was the maternal health and prematurity period of risk, the blue box, and they found with Kitagawa analysis that the problem was that there were too many very low birth weight babies. That is not a survival problem, it's just that too many babies are being born too early. So they were looking at risk factors for the babies born too early, and they compared the population, the study population, which was Black non-Hispanic babies, to the state reference population. And it's just the prevalence of these risk factors. So there are some risk factors where the Black population has much higher prevalence, and those might be important. And then we'll do further analysis. We can look at this prevalence and look at prevalence differences. And this is prevalence among the population that we're studying. And we can also look at risk ratios, is how dangerous the risk factors is also important, not just the prevalence. And we can move from there to add population attributable risk as a just a summary measure. And we can talk about this some more, but this is not really a PAR in the research sense when you're trying to identify causes. You know all these things can be causes. but you're trying to figure out, it's just a way to summarize both the percent of the population that has the risk factor and how risky it is. It's summarized in this one number, and that allows you to sort of rank the risk factors and tell the community which ones really are likely to be playing a big role in your community. And here are some examples of what you might bring to a community after the PPOR analysis is done. So in this case, we found that too many very low birth weight births contribute 75% of our preventable blue box deaths, 31% of the whole excess mortality, and we found that the factors that seem to be important in our community are not being married, having a high school or education or less, short birth spacing, and previous preterm birth. Now, some of these are not really causes. We don't think that if people got married in the hospital birthing room that their problems would be over. We do think that they are markers. They represent a population and a bunch of social circumstances that are different from place to place to place. So we would need help from the community to interpret the meaning of factors like these. But just as important as that column on the left is the column on the right that says the factors that are not likely contributors. So these factors are things that maybe our community's been all worried about: teen births, smoking, obesity. Those are very prevalent and they are important, but they might not be contributing to the particular problem of excess mortality that we have in our community, so we need to maybe focus on these different things. And this not married in high school or less are really pointing to social structures. And so that may be motivation for your advocacy groups to really address social structures and not just medical things or chronic disease issues. So, if you haven't already guessed, PPOR really does foster integration with other key efforts that are going on in your community. Community health improvement plans, community needs assessments. Sometimes those include surveys of community members. The other surveillance systems, even if they're at the state level, they can sometimes help inform you, especially about a small population group that you can't really survey in your community. Policy and program evaluations are really important. If you've got evaluation results, use them. And use programs like the Fetal Infant Mortality Review, as I mentioned before. That really adds a lot of information that we need. When we're just relying on vital records, it's not enough. So this is a very quick introduction. I'm glad you can come. I hope you enjoyed delving into the articles, and the homework assignment is really fun. And it's real data that Bill Sappenfield pulled together from a paper that was published. And feel free to email me if you have questions. And it would be delightful to get questions before the talk, so I can be sure to include the answers or discussion time in the talk. Thank you very much.